So, good morning, good afternoon. Welcome everyone to this EHDEN webinar. Today, I'm in conversation with Ismail Gögenur from the Denmark's Center of Surgical Science. He is a surgeon by training, and what we want to do today is to discuss how OMOP and OHDSI can help him to eventually even prevent deaths. We will get into all of that shortly, but I would like to start with inviting Ismail to introduce himself and say a bit more about the work that he is doing in his center.
Yes, hi, and good afternoon from Toulouse in France. I'm a professor of surgery and practicing at Zealand University Hospital in Denmark. We are a research unit where the major focus is on the clarification of what are the drivers of morbidity and mortality in patients undergoing surgery. And we have a special interest in oncological surgery. And I'm also personally a colorectal surgeon, so this is also my clinical daily life. What I have experienced as a surgeon, as a clinician through many years, is that there is a huge variation in the response to what we do as clinicians, variations that we cannot anticipate with our usual clinical tools. So it has come to me that we need to have a more precise approach to identify patients that can be treated on the right way at the right time with respect to their oncological surgery. And this is where I have been heavily investing in the last couple of years to try to find the right platform to build up in order to find the right tools to stratify patients. And this is where the work with the OHDSI platform is of huge value for us.
Thank you, Ismail, for introducing yourself. I also mention now that this webinar is part of the EHDEN project. If you are new to this webinar series, or if you would like to know more about the EHDEN project, then I would encourage you to especially watch one of our earlier webinars on what is the EHDEN project. Returning to Ismail, maybe you can also say a little bit more about why you started this center. I think that was a couple of years ago, and what is the type of research that you're doing?
Of course. So we initiated a Center for Surgical Sciences a little more than 4 years ago. It's a research unit. At the moment, we are a little more than 30 full-time employees. It is primarily medical researchers, medical scientists, that are doing clinical and translational research. So we're having research methodologies spanning from in vitro investigations, clinical trials, and epidemiological research, all to cover the aspects of the complexity of a patient undergoing oncological surgery. Within the last 2 years, we have expanded our research unit, including central players that can help us understanding the complexity of the data reality that we are creating with the different research methodologies. So we have had the luck to appoint Yanis Drakas as a key member in our group, who is experienced in the OMOP CDM platform and who is the leader of the work package in our research unit concerning data science. So right now, this collaboration between data scientists, bioinformaticians, clinical scientists, senior clinical scientists, junior clinical scientists, is a absolutely interesting environment, because there's this cross-disciplinary approach and understanding of the clinical variation, complexity, and the data variation and complexity.
Right. So, Ismail, I understand from our previous conversations, I know that you are in fact still practicing as a doctor, which means you are probably in a good position to give us also a bit more the medical context of why you are doing all this research and what is the impact on it, just on treating patients.
Of course. So the primary issue, the problem is that when we do surgery, even if we do state-of-the-art, minimally invasive surgery, robotic assisted or laparoscopic, 30% of our patients will suffer from a complication after surgery. And this complication has a huge impact on the patient's recovery, risk of death within 30 days and 90 days. So we produce the same high quality of perioperative care. We produce the same quality of surgery, but 1 out of 3 patients have a complication after surgery. At the same time, when we're doing oncological surgery, we are also sending 2 out of 3 patients home with the message that now they're cured. They don't have any more cancer left. We have operated it and removed their colon. Even if we do that and we can send them home with that message, 1 out of 3 patients comes back to us within 3 years with a recurrence of their disease. This recurrence has a huge impact on their mortality and obviously their quality of life. Needing systemic oncological therapy, needing new surgery. So there is something we do wrong right now. We are not good enough, we're not precise enough to have a focus on those high-risk groups in order to find out which patients could I, when I have a newly diagnosed patient with colorectal cancer, which patient could I take out and prepare for surgery? Give them, for example, oncological therapy before surgery, prehabilitate with them, train with them for 4 weeks, correct their blood samples with respect to, for example, if they have anemia before surgery. I don't actually right now have a tool which is sensitive enough for me to find out which patient will suffer from these poor outcomes. So this is the main focus of the clinical problem. It's to try to identify these high-risk patients.
Right. So just to reiterate that a bit, you are a surgeon, but you're also talking about oncological therapy, by which I think you mean drugs that
yes,
that are one of the options for treatment. So you have surgery, you have drugs. Are there also other things that you have to take into account when making a treatment plan for these patients, or in the data that you're mining?
Yes. So obviously, there is one extreme choice, which is not doing anything, because the patient's risk of having a complication or dying for the treatment that we are suggesting is too high. This is a value for the very elderly or patient with comorbidity. The other factors, with respect of the oncological therapy, this is primarily immune therapy. We need some translational markers, which may span from very, very standard markers that actually is a standard package of any colorectal unit in the world evaluating a patient before surgery. This could be simply just looking on the white blood cell count and see how the distribution of neutrophils and lymphocytes, two subsets of this white blood cell count, if we had those data standardly on our patients, we could actually find out what patient is in high risk. Other data, which is important, is data regarding frailty. Why is frailty important? It's for us to make interventions that can correct their frailty. So in Europe, for example, both in Netherlands and the UK, we have cancer packages where the standard is to try to operate the patient as quick as possible. If I have the data to say that this patient, due to his or her frailty, has a high risk of having a complication, I might better delay the cancer surgery for 4 weeks or 6 weeks and do muscular training, give the patient diet with high protein intake, and correct the patient's situation and then operate. So the data are not merely, you know, there's a tumor in the right colon, this is of this largeness, it goes through the bowel wall and there's lymph nodes, or it's this histological subtype. It's also all the other stuff that affects the patient's outcome.
Right. So I want to ask one more follow-up question before we move to the next topic. Just playing devil's advocate a little bit. So it seems that as a doctor, you have a clear understanding of all these factors that possibly affect the treatment options that would be best for the patients, as well as the options themselves. So why do you need all this data mining, data gathering, all these researches that you have in your team? Isn't this just, let's say, the art or even the science of being a doctor, that you as a human have this experience from previous patients that you saw, as well as from your training, and that you apply this knowing everything you know about the patient? Why is there a need for sort of advanced data mining and statistics?
Yeah, Case, this is a very, very excellent question, and it is in the center of this whole shebang about, you know, using big data in clinical science. The obvious question, or the quickest question, might be just to join a multidisciplinary team where we sit as a surgeon, oncologist, radiologist, pathologist, and go through every single case. So the data granularity, or the amount of data that we digest within that 2, 3, 4 minutes is highly selective and depends on almost random issues. So even if we are individually good clinicians and collectively even better, we can only include 5, 7, 8 essential information, and it tends to be more focused on what is my expertise. I, as a surgeon, I say that I can operate this patient because there's no technical difficulties. The oncologist thinks, okay, this patient is of pretty good performance status, I can give this patient oncological therapy. There is an overlap in our competencies, which has a huge impact on the patient's outcomes, which we do not see. And there's a very good example of this Spanish study going in and trying to predict the risk of a patient having an anastomotic leakage. This is a situation where we as surgeons fuse the two bowel walls, and 8 to 10% of our patients, the sewing or the anastomosis ruptures, and this is a very dangerous complication. This group made a clinical algorithm, a prediction of the risk of anastomotic leakage, and then they tested it with surgeons, you know, real good, long experienced surgeons, and the ROC curve, the AUC was terrible for the surgeons, and the algorithm was actually doing much better. It was 0.68 or something, and the surgeons was a 0.49 or 51, something like that. So even if we say, I can see the frailty, I can see what my patients' need are, this is not actually reflected in the reality, because we don't do good enough. We still have a lot of our patients suffering from complications and suffering from recurrence.
Okay, thank you for these great examples, Ismail. I think that underscores indeed the importance of what we're doing. But then maybe if we move to the next topic, working with data to help you as a surgeon to make better decisions opens up a whole another can of worms, because first of all, the data is messy. It comes from many different sources. And then there's also the issue of the risk profiles. So let's start with the data. Can you tell us a little bit more about the data that you now today have at your disposal in colorectal cancer or bowel cancer, in the research that you're doing from Denmark?
Yes, certainly. Just allow me to share a single slide with you guys. At the moment, the sources that we have is within different national databases, data registries. For example, we have a registry for colorectal cancer, we have a registry for anesthesia, for pathology, for microbiology, for a registry encompassing data regarding causes of death. We have biochemistry data, and we have the medication within the hospital. So these are the data sources that we have, and as you say, Case, these are obviously heterogeneous, and they are, I think you used the term messy. However, as it is in the Netherlands and other Scandinavian countries, it is of high completeness, so it's of high granularity, and we actually have a very thorough representation of all patients with colorectal cancer due to our security number or health security number that we have on individual patient level. So we have detailed, high granular information on all these patients, and obviously, in order to digest this, we need a tool to standardize these concepts and these terms, and this is where the OHDSI OMOP platform is of crucial value for us.
Right. Okay. So you have all these different sources that you enumerate here on the slide that you showed to us, and then even within those data sources, there are different terminologies that are being used. And I think this is one of the key problems that we try to address in OMOP OHDSI. So before we move there, maybe a quick explanation for those of you who don't know what OMOP is. OMOP is a common data model, which is meant to contain the full medical history of a patient as it pertains to analysis for the purposes as like Ismail is talking about today. So you would have conditions that are observed on the patients, drugs that are taken by the patient. You have the observations such as lab measurements that are taken or that are observed. And the purpose of the OHDSI community is to have a global standard which allows us to compare this data from multiple countries, health settings, and even within a country to merge different registries as Ismail is doing. So with that intro, Ismail, my question to you is, on the specific topic of mapping terms, is this something that you have in Denmark? So for example, I can imagine that a registry that is focused on colon cancer will have more detailed information than just the hospital EMR, because the registry may answer additional follow-up questions for the patient, which may or may not make its way back into the electronic medical records of that hospital. So is that something that you're dealing with in Denmark? And can you maybe give us some examples of how you're dealing with that and how OMOP helps in that?
I'll do my best. So I think the first concept is to realize, exactly as you also outline it, that the registries are made or put out there by the Danish government in order to make quality improvements. So the registries are governed by primarily clinicians within the clinical fields, and they define what kind of outcomes are of interest for that specific area. For example, for diabetes, it might be a registration about leg ulcers or feet ulcers. For colorectal cancer surgery, it is more the occurrence of complications, for example. And the clinical grading of complications will be an information that is within the registry, but which is not retrievable within the electronic health record. So here we get some unique information from the registries that has a huge impact on our understanding of outcomes, for example. There are different other examples of kind of heterogeneity among the data sources and sources directly from the electronic health record. I think we can allude to this in more detail later, going on with respect of fusing data from data sources to the OMOP CDM platform. But obviously, just to underline the fact that you brought on before, this is a richness. It's an addition for us that we have these additional data that is not just coming from the electronic health record.
Right. Yeah, I think when we spoke before, you gave me an example of a procedure that is performed by surgeons, and it's very important to have the details on this procedure. And I think one critique that people may have on using a global model like OMOP is, for a specific case or for a specific question like you have on surgery, are the terms indeed granular enough? So can you tell us a little bit about how you dealt with that in the project? So how do you ensure that the OMOP mapping and the terms that you have once you've harmonized the data from these sources actually have enough granularity so that you confidently dare as a surgeon to use that information to make potentially life or death decisions?
Yeah, so this is also the critical point of what we are doing. Let me give you an example of the granularity issue. If we go to the specific process that we used, I think one thing I need to underline here, as you can see in this slide, is that the coupling of data granularity and the data quality to a clinical grade system which can assist me as a clinician, clinicians in general, to make medical decisions. This includes a very vital collaboration between data scientists and clinical doctors and clinical scientists. So this is the first step. Before going into a discussion regarding granularity and the impact on patient treatment, I think that we first need to be sure on that our data are true. So the trueness, so if we map data from the sources to the OMOP, this loss of granularity at what level is this? Let me give you an example. From the Danish Colorectal Cancer Registry, we map or we register different ways of having a left-sided colon tumor removed. So it has different names. It can be called sigmoidectomy, it can be called a sigmoid resection, it can be called a Hartmann's procedure. At the end of the day, the granularity in our source data is actually not needed to be granular for in a biological sense. So we lose some granularity when we put it into the OMOP platform, and this is not a negative thing. This is a medically driven mapping issue, which I think is crucial. The other part is the inconsistencies. If we are to use source data and automatically map them into the OMOP, as you can see in the data that I'm showing here, provided by Yanis, we had more than 46% of improvements in mapping quality, where some of them were wrong. So this is automated software going through our source data and mapping them to the OMOP CDM. And these were corrected for the larger majority. And this is a result of this team of medical doctors that were going through these data. And this, I think, is also addressing one of your worries, Case, regarding using OMOP CDM as a platform for clinical grade use, is that these data should be digested, should be gone through this team of doctors and data scientists. We did it like this, that we had this team meeting every 2 weeks, went through the mapping files, and then we had a task force of a smaller group who kind of double checked the quality of the data. We had, as you can see here, I'm not going to go through the details, but we had detailed and standardized approach to identifying the source data and the grading in the CDM, and make sure that every single row was true. And I will give you an example. For example, here on the left side, you have the Danish classification for something called malignant cachexia, which is a situation where a patient with cancer does not eat and therefore loses muscle mass and loses weight. If you see, we have some extensions in the Danish system. We have 4, 5, 6 extensions, and if we make a match to the ICD-10, it will be matched wrongly as a malignant neoplasm. So it will be mapped as a tumor. So when we find this, we obviously go in and find exactly the same or the right SNOMED CT code for cachexia. So the data going into the clinical grade tool are true. So just to outline this one more time, I could have this situation. I have a patient who is a female, 64 years old, has a colon tumor, stage 2, and is classified as having a primary malignant neoplasm of unknown site. So the colon tumor can be considered as a secondary condition. In the right side, I have the true situation where I have the same patient experiencing discomfort and weight loss because of cancer. So if I did not have this detailed approach going through every single column, we might have this wrong mapping. And this is where I think the most essential part is to be sure that the the data is true, and maybe not be worried that the granularity is lost, because again, I think the control of the granularity should be inspired by the clinical community. And if, for example, Case, I think this is also one of your points, if there is, for example, a crucial data that we store in the colorectal cancer database, this is exactly what I want to communicate with the OHDSI community to make the right concepts so I can actually map it to the OMOP. And this is, again, one of the advantages of this dynamic community, that this is possible.
Right. So to the audience, I would say, if you have any questions, please feel free to ask them. We will address them as much as we can. So Nuno da Silva already asked a question which I think is very pertinent to the topic that we're discussing right now. So Ismail, it is super to see all the things that you're doing in Denmark, working with the data that you have and conforming that to OMOP, making sure that the quality of the mappings is there. But Nuno's question is, how can other clinical sites benefit from the data in your sites? And I would maybe sort of extend that to how much of all the detailed work that you just described can be reused by others in the OHDSI community?
Yeah, so I think that you are moving into a domain where my answer might suffer from my lack of insight on a global level with respect of data sources in different countries. My immediate answer would be, obviously, we need to develop predictions of essential outcomes, and we will see what are these predictors. And I think that many of our neighbor countries will be able to use the documentation that we use in order to implement it in a clinical grade OMOP system, and will be able to use this in their development. The data granularity is obviously an issue. We have had these discussions with Peter Reinicke. We have had this discussion with Patrick as well, Patrick Ryan, regarding the prospects of what we are doing. For example, in Turkey, when we had this retreat in the OHDSI clinical evaluation or making prediction models in the clinical setting, we have a clear plan and a perspective to reproduce what we are finding externally. So validate this within the OHDSI community, finding out the partners, for example, in Colombia or in Rotterdam, that can see the prediction models that we are developing and validate that we can, so to speak, reproduce our predictions in their models. Another thing, again, as you can hear, Case, this is where my insight into the OMOP tools are beginning to be challenged a little bit. There is the network opportunity as well, where I'm thinking that if we have colleagues around the world that have a basic OMOP CDM constructed and they have patients in their clinic, I think that it should be a task for the community to try to find out network models that where they can dive into our data and use those algorithms to make predictions for patients overseas or anywhere else in the world.
Right. Yeah, and maybe this is also a good moment to remind everyone that in the EHDEN project, it is exactly our purpose to build such a network in Europe where we can learn from each other's data without having to put all of that in one big database. So for privacy and all sorts of reasons that will not be possible. But thanks to mapping to a common model, OMOP, we can indeed, for example, build a prediction model on one database and then validate it with another or use it in another. So I want to zoom in a bit more on those predictions, but before we do that, there was another question from Gonzalo, and he asks, how long did it take you to make this mapping that you explained, Ismail?
So let me just show you the initial slide here. We had a 4-month stretch from March to June with an intensive phase going through these concepts with 12 medical doctors and Yanis and Nico heavily integrated in this work, leading this work. So this was the amount of time used.
Okay, and what kind of team did you employ for that mapping?
A kind of team?
Yeah,
so these were, yeah, sorry.
You mentioned here on the slide 12 MDs and 6 MDs, but I'm sure there's also technical people involved.
So these the collaboration is also heavily assisted by a collaboration with the Odysseus company,
Right.
which has been assisting us in this work, obviously.
Yeah. Okay, so I think that's a good answer. And if there's follow-up questions, people online, please feel free to ask them. These webinars are also meant as an interactive way for us to engage with all the people that are following the EHDEN project or that have a stake just in using data to improve medical practice around the world. So let's then move on to this topic of machine learning and how are you actually using the data, the models that you're building. In the beginning of this call, Ismail, you explained to us that as a doctor, if you don't use the tool, you only have limited slots to interact with your colleagues in multidisciplinary meetings, and that having the data and also an analytics on top of that, so having the data OMOP and being able to use OHDSI tools can really help you to make better decisions. And I think part of that is explained in one of the examples that you gave about risk. So on the one hand, you have the data from the one patient that you're looking at. On the other hand, you have the background of all the patients you've seen before and in the future, possibly also from other countries around the world. But then how do you use that to really make a better decision? You need to build, I guess, sort of risk profiles, which can help you, right?
Exactly. So let me just share a slide with you. The first step is to, when the patient comes with their diagnosis of colorectal cancer, I register I extract the patient data and I put it into the model of interest, which has the most impact on the clinical course of the patient's trajectory. So, for example, if my goal is to find out, can this patient go through surgery, and sorry to be direct, without dying of complications, I will need a model which can predict the risk of 90-day mortality. So the essential part is to make the model and to have a prediction of that individual outcome, which is, for example, 90-day mortality. So the next step, I think, is of crucial importance. So when we are in the multidisciplinary team, we are clinicians, colleagues that have limited time to make a decision. So one of the initial steps that we are doing right now with 2 medical PhDs and 2 non-medical PhDs will be to dive into this interface between the clinical environment and the prediction. How can we make sure that the clinicians get what they want, and how can we make sure that the model provides the information that is needed? So this is one of the crucial points. It's to convey the data from the risk prediction tool to the multidisciplinary team. So this is just one step, and this is again something I think is very important to underline. It is a decision support tool. It's not going to be a final suggestion, but it should be a support giving essential information. Then from there, I think as clinicians, we need to provide, or as researchers in surgical pathophysiology and interested in the different toolboxes that we have in order to modulate the patient trajectory, we should have a recommendation. The doctors, the multidisciplinary team should have recommendation if we should prehabilitate the patient, so if we should train the patient, if we should do surgery of special kind, if the patient should have oncological treatment, or if we should not operate on this patient because of too high a risk. So this is the course for the patient when they come with their diagnosis. I think, if I may, Case, just point out the essential points during the patient trajectory when the patient is going through surgery. There is obviously the preoperative phase, but it's also very important to have a tool that can help me as a surgeon when I'm doing my surgery to have a prediction of what then. So when I did the surgery and there was an incidental bleeding, the patient got a blood transfusion. This has a heavily impact on the outcome for the patient. The patient, if the patient had gas anesthesia, or if the patient had an event during surgery with low blood pressure, this should be live data fed into the prediction to the common data platform and produce a prediction at gloves off. So when I take the gloves off and I'm finished with the patient's surgery, I need to have a prediction of how to approach this patient for the recovery phase. Mm-hmm. When that has been done, I need to have the data from the recovery phase at the time of discharge, because this is a very important thing, Case, and I hope that the audience agrees with me that this is not a colorectal case. This is orthopedic, this is a gynecological surgery, this is a thorax surgery. It's exactly the same drivers of morbidity and mortality. So when I'm discharging the patient, I need to have data from the whole trajectory up until the discharge, and then I need to see how should I approach this patient. Is this a high-risk patient where I need to do, for example, additional data collection with wearables after discharge in order to identify if patient is about to develop a complication and then intervene and prevent it at that time? Should I put adjuvant oncological treatment? So should I put some extra treatment because the patient has a high risk of recurrence? So I hope it's clear from this slide that the tool is not just a single shot tool at time of diagnosis. It's also during surgery and also during post-operative phases at discharge.
Right. Well, thank you, Ismail, for challenging the audience. So if anyone has a different opinion or clarification, please feel free to type that in the questions box. But for now, I already had a follow-up question from Gonzalo again, which is, assuming that all hospitals have the same OMOP model, is the data aggregated somewhere outside the hospitals? And if not, what is your experience in applying models from other hospitals in yours. So I'll actually take the first question. At least in the EHDEN project, our goal is definitely not to put all the data in one place. It is to keep the data where they are, possibly aggregate where it's legally allowed, as Ismail explained for Denmark, but then be able to run, for example, the same prediction model on multiple databases, either for validation purposes or else also, and this is now hypothesizing, Denmark has very detailed data. And I think there are few countries in the world where you actually do have this level of detail and where you're allowed to make the linkage between all the various sources. So in a way, this is a unique data source. And there's some other countries, as you mentioned, that have a similar setup. But can you speculate a bit, Ismail, even if you would, let's say, build a great model for post-operative discharge risk profiles and sort of the decisions that you could take, if there is an other single hospital or a country where they have less granular data, do you think that you could train a model on the Danish data and then use that elsewhere? Or is that still an open question that needs to be researched? What's your position on this?
Yeah, extremely good and also a little bit difficult question for me to answer. I think that what our limitation is in Denmark is certainly not granularity. This is our strength. I think that it's a standing discussion. What is of highest importance? Is it the high number of patients with low granularity for building a good prediction model? Or is it more granular data, including more data that drives outcome or the variability of the what we're interested in on an outcome basis for the patients? I don't think that anyone can come with a firm answer on this. I think this is exactly one of the things we need to answer in the future and this is where I think the OHDSI community really is going to be of value, to have these cross validations and answer these questions exactly. So this is on the scientific part, testing our prediction models in Dutch data, or a better example could be outside of Europe, but also and this is one of the interesting aspects as I can see it, we are trying to create the environment where the storage outside the hospital in a safe environment, if this can be created in a fashion where the global community can access some of these platforms in a fashion, in a way where there is absolutely no legislative issues or problems. This is some of the things our team is working very hard on to clarify, and I think it will have extremely good consequences if we can get to a reality where this is the fact.
Yeah, it's also one of my personal drives, I guess, and yours, and I think many in the OHDSI and EHDEN community and beyond, to be able to use patient data to improve health and to improve medical outcomes. But as you say, it's very important then to be able to access the data. And one way to do it, I'm interested in your opinion on this, if there's no other questions from the audience. So in the Netherlands, we have a program called MetMij, where the government is setting standards for interchange of data between GPs and hospitals and also patients themselves. And one way to sort of get data out there quickly is, instead of the hospitals or other parties sort of keeping the data for you, to enable the patient to pull their own data from all the sources they have, and then under their consent made this available to the global research community. So is this something that that Denmark is also working on?
So I think that this is a very sensitive matter, and it's more feelings than knowledge that is driving this. We're having these discussions frequently in the media in Denmark. I think that there is people are afraid, obviously, that the individual patient will lose control of their own data. I think if, as a community, we should maybe take the first low-hanging fruit and create an environment where it is without any possibility to make, identify any individual patient, so that we have a platform which is completely anonymized, or as close to anonymized as possible, and then make that data available for other countries, other clinics, in order to dive into that platform and use not individual data, but the algorithms created in that, just to come with the data. Just for an example, the data from patient in Argentina can be put into the model in Copenhagen, and then we'll have a prediction based on the data that is provided from Argentina. Obviously, this sounds like maybe a little bit out in the future, but I actually think that this is an achievable goal, and that the bridge to that is through us being better at validating our data sets across countries.
Right. Yeah, so just to remind us also of the title of this webinar, and sort of the grand plan for the future is to use this, all the technology that we're building in the end, to also reduce cancer deaths and complications. So you already mentioned the example of Argentina, but what concretely is your perspective in terms of time? Do you think this is something that we can show some concrete results on in the coming years? Like in EHDEN, yes. We are already running for a year. Do you think that we'll be able to show some compelling examples? And if so, is that going to be next week or next year or in 5 years? What's your perspective on it?
So right now, I am very happy with the progress that we have. The clinical grade system is under development, and we are very focused on creating the first story in the clinic, and are also very focused on having a significant clinical issue. So I think that if I were to anticipate the progress that we are making within the next 1.5 years, I think that we are in a position where we will be able to provide this tool to our clinicians in order to have the first pilot patients going through an evaluation process where we can use our common data platform. I might not be precise in 1.5 years. I'm just trying to say that this is within sight, and maybe it will be a little bit longer, maybe it will be a little bit shorter, but certainly we get the scent right now.
Okay, well, that's a great perspective to have, Ismail. I can't wait to have this conversation again once you're there, to walk through some of the results and show how we hopefully by then also have leveraged the EHDEN network to connect data sources across Europe. Maybe this is also a good time for me to remind anyone that is watching this that we have a current open call from the EHDEN Consortia for data sources. So if you do have patient data in some form for example, from a hospital or a registry, or even a set of GP practices, as we had in one of the previous webinar from Catalonia, then check out the website ehden.eu and look at the call. So what we are offering is an option for a grant to help you get started with mapping the data to OMOP and leveraging the OHDSI tools that can build prediction models like Ismail explained in this call.
Okay, may I make a just small point for the prediction of the 1.5 to 2 years? So right now, the first experience that we had with this proof of concept work that we did together with Patrick and Peter and our research group, we created a prediction model with an AUC of 0.86, and this is with a reduced data source. So obviously we are interested in creating the platform and making the prediction using a tool with an AUC of 0.86. I think this is achievable. If we are to integrate 26 data sources, it's a different issue, but this is what I'm trying to do as a clinician, is to try to create the situation where we'll stress us as clinician and stress our hospital system, etc., and create the first story and see what are the weak points, what will be the childhood diseases of the system, and cure that before we, aim for the grand total 25, 30 data sources on millions of patients. I think that's where we are in our development.
And did you publish these models as open source software, Ismail?
Excuse me?
So are these models open source? Can others access them and run them on their own data?
This is a part of our progress right now.
Right. Yeah, there was a question about that. So I think in general, the OHDSI community, all the tools are open source. The models are published, and hopefully as much as possible open source as well.
Of course.
We are writing, in effect, at the moment also a book of OHDSI, which for anyone that has questions, I would encourage you to check that out already. It will be published soon, but it's already available online on the OHDSI website. So I have some questions about the mapping and details on that. Unfortunately, we are out of time. So maybe one of our next EHDEN webinars should be also more in detail about the mapping process, of which you gave some great examples today. But for now, Ismail, I would like to thank you very much for all the insight that you gave us in how OMOP, OHDSI, and EHDEN can help you as a doctor to treat your patients better. And I would like to thank everyone watching this now or later for your participation. And if you have any question, please feel free to reach out to EHDEN on Twitter or via the website. Thank you so much.
Thank you very much for the opportunity. Thank you.
Thank you, and bye everyone.